So just a brief introduction of Dr. Iqbal Malik. He's a consultant cardiologist at Imperial College. He's also the clinical lead for TAVI procedures and the director of the structural heart program. And he's also involved with the research center there and has many publications. And also he's a good friend. So Iqbal, all yours.
Okay, so I'm not going to go through the data because there's no way I could match Professor Taggart's incisive brain, and the data, as he said, is the data. So I'd like to share my thoughts. So my conflict of interest are that, of course, I am an angioplasty doctor, but actually, unlike all those American patients, I've actually never told a patient having an elective angioplasty that I'm making them live longer. I've never told them that it reduces their risk of heart attack. I've told them it's for symptoms. And actually, I think that's not too unusual in the UK. I think American cardiologists have got themselves into difficulty because of the payment by results, which we don't have in this country. But it is surprising when I say that to patients, as Professor Taggart has pointed out, they are bizarrely surprised that I've said that because their assumption was that this was a life-saving procedure. So I feel slightly nervous because just as David often appears in interventional cardiology meetings as the owl amongst the cats, in the same way I'm feeling that today, but I thank you for the invitation. So I suppose my take on it is that, first of all, this audience needs to understand what coronary artery disease actually is. Then I think, as David has pointed out, that we actually do need to get people onto best medical therapy, because if many of the earlier trials were done against the best of medical therapy with 80 milligrams of atorvastatin, the benefits might well be much, much smaller for the revascularization. The data now you know in detail because David has shown it to you. I will highlight again, because it needs to be highlighted, that complete revascularization is the target. If we don't have complete revascularization with any technique that you're using, you have failed. And then I would like to see if your hospital has a robust MDT and what your unit's outcomes actually are. Because whatever the outcomes are at Imperial, where I work, or where Professor Taggart works in Oxford, are completely immaterial to the patient in your hospital unless you're referring to us. And then finally, I think for most patients, the decision probably isn't binary, and their views need to be taken into account. Of course, the special consideration of the diabetic patient, the left main patient, the LV impaired patient, and the CTO patient have already been mentioned by Professor Taggart. So we'll come back to these questions. As I was listening through the talk, I was going to ask the panel, we'll ask at the end maybe in discussion, what a short left main stem, fairly easy to stent, and a short proximal LAD lesion would lead them to actually have if it was their body and not the recommendation to a patient. And also the idea that although Professor Taggart mentioned the nitric oxide, actually we so often see that native coronary artery disease progresses really aggressively after you had a bypass operation. All the proximal vessels seem to block off, although I completely accept that the distal vessel does not. And this new concept that Syntax arrived with at the MDTs, certainly at Imperial, we scratched our heads to see why wasn't everyone else doing that, because I started training in cardiology in 1995, and pretty much since then we had a robust MDT led by Rodney Foll, so maybe he was ahead of his time. So let's first understand coronary artery disease. When you get a report of an angiogram, it often says normal. I don't believe anyone age 50 has completely normal arteries, it's just you haven't seen it on the angiogram. So they're bound to have atheroma. And then the atheroma turns into a stenosis. The stenosis often judged by an angiogram. And in these sort of stenoses, then you start thinking about revascularization if you think it's significant, lambs to the slaughter. But then, of course, there's the left main stem, and still a number of my colleagues get very frightened about left main stem coronary artery disease and how they might treat it. The angiogram, I think, is flawed in many ways. You could think it's significant because of overlap. And for example, this left main stem still that I've shown you, there may be something in the distal left main stem. Every projection showed a similar thing, but was it significant? And so that's where non-invasive testing with either stress echo, MRI, or PET come along, and invasive testing with the many modalities of flow and pressure drop And illustrated in this particular case, we're at that left main stem. You can see by that illustration, all the yellow dots, because cardiologists in Den are very simple people. We like to see simple things. So all the yellow dots are at the left main stem. So this was a very significant left main stem stenosis. So the angiogram, if you're basing all your decisions just on that, may well be flawed and a recipe for the patient getting no benefit from the revascularization. If we then don't deal with the other modalities of treatment, we've again failed. There are two groups of patients, obviously, the ones who are acutely unwell and the one with chronic disease. And again, perhaps the discussion with the panel is whether the surgical panel has ever taken a patient with an ST segment elevation myocardial infarction directly to theatre, because in my whole career, I've not managed to twist any surgeon's arm to do that. If you have medical therapy, then the antiplatelets are key. The statins are even more important. There's benefit for ACE inhibitors, and most recently, 2 New England Journal papers saying colchicine was a good idea as an anti-inflammatory, because atherosclerosis in the end is an inflammatory disease. And whatever we're doing with stenting or surgery, if we've not got the patients on a whole host of these other medications, then we have failed and the prognosis will not be good. In terms of symptoms, there are 5 available anti-anginals, and those probably could be stopped if you've had successful revascularization. So when we're discussing revascularization, as Professor Taggart has mentioned, it is a very odd field because you could get a balanced opinion. But as this seesaw illustrates, perhaps the fulcrum starts moving, and that is difficult to judge unless you know the data. Then you have the weight of the evidence base, and even when you have that, then you have the wishes and expectation of the patient to deal with. And when we were having a preliminary chat, David and I, then he was fairly clear that he's able to convince the patient of the wishes of the MDT and get the right answer in almost all cases. And it must be a very different population, because I find it extraordinarily difficult in some patients to lay it on the line and say, I'm refusing to do angioplasty because surgery is so much better, and then they refuse to have anything at all. So these patients in West London clearly are slightly more difficult than in Oxford. So when we're talking about these trials, then perhaps the surgical approach, when we haven't had a complete revascularization, is that there weren't enough conduits, that it was too small to graft. It was an intramuscular course. The vessel was very heavily diseased, much more so than expected from the invasive angiogram. And then, of course, the interventionist comes up with the same situation where they said, oh, the lesion took too long to treat the first one, so I stopped. Oh, it was a chronic total occlusion. I can't do those. I thought it supplied dead muscle, therefore I didn't graft it. It's only a side branch. And all of these things in both our groups need to be avoided if we want to get complete revascularization. And then I suppose we need to discuss what's important to the patient. We've touched on that already. Now, the fact that they become asymptomatic will be important to some. No repeat procedures, no myocardial infarction, and actually no stroke. So many people actually rate stroke much beyond death even. If you start talking about MACE and MACCE to the patient, I think you'll have lost them. So I think we need to be straightforward with them. When we talk about patient preferences, there's the stated preference, which is a cold, light of day situation when it's not your body. And it's sort of what I would do for my brother. I could be very clinical when dealing with my brother, who's only 1.5 years younger than me. If he suddenly had angina and he had an angiogram, I'd produce an evidence base, probably based on Professor Taggart's talk, and tell him exactly what I thought. And I used to think that I would do exactly the same thing if it was my body. But actually, as I get older and that intervention becomes closer to me, I've increasingly come to realize that what I would do for me may not be the same as what I would do for my dad or my brother. And I think we need to take that into account, because the stated preferences could be based on the patient, the caregiver, or the physician, and also understanding what the preferences are, including what available treatments are. But stated and revealed or genuine preferences are actually slightly different, and the revealed ones have not been heavily studied. So from our group, Ahmed et al., there was a clinical weighting, which obviously in all these trials made bypass surgery a clear winner. And that was on the evidence base that we as clinicians understand. But if you weighted it by patients' preferences, then those differences disappeared. I'm not saying that's right or wrong, but it's what's going through the patient's head. And you can see there have been a limited number of studies trying to get these preferences teased out. And it's remarkable how often stroke comes out as the dominant factor that is preying on the patient's mind. And as I get older and closer to an intervention, then I too am thinking that actually being debilitated by a stroke would be far worse than having another angioplasty, or indeed having a heart attack, or indeed dying. So what about your MDTs? Well, they're overloaded at the moment, and we can't have an MDT every day, although in London now we actually do have the offer of a daily MDT, which remarkably is not actually taken up very often. So most patients get discussed at the weekly MDT. We can't discuss every single angiogram, and so we do need to have a protocol for which ones we really do recommend get to the MDT, get off the table. The three vessel diseases, probably. The left main stems, I think, certainly. The proximal LAD, probably. All of them impossible to actually do in our current service. Okay, so how do we assess them? Well, the Euro score, okay, fine. Does that truly equate to frailty? I think probably not. Frailty is extremely hard to judge, and that's where angioplasty versus surgery may have a role. And what are your local results? Because this will give you a general result. And I still am harping on about the fact that you need to know your local results. So here's an example bubble plot. The actual one that came out of the syntax trial circulated for a while and then has disappeared from trace. These are in a randomized controlled trial. This is not actually the one from syntax, but it's an example. You would hope that there was a line of equivalence of PCI and CABG risk in a randomized controlled trial, or perhaps the slope was in favor of surgery, or perhaps the slope was in favor of PCI, a diagonal line. What you would hope is that most centers were lying close to that line. But let's imagine we were one of those two red dots. In this randomized trial, perhaps in your unit, the bypass risk is phenomenally high and angioplasty is low. Equally, if you're at the other dot, the other red dot, but perhaps your bypass risk is remarkably low and your angioplasty risk is very high. And I think I find it very difficult to tease that out in my own center as to what those appropriate risks actually are. And unless we know that, then it's very hard to apply the trial data. So what's the viewpoint? Well, I think Professor Taggart's view is, of course, that a bypass wins hands down. And that's a clear winner. That's actually Michael winner. I would say that certainly bypass wins hands down in diabetes with multivessel disease, diabetes with proximal LAD, multivessel disease with left main stem, and multivessel disease with left ventricular impairment. Those people really should be having a bypass operation. But perhaps it's okay in the non-diabetic with a low syntax score multivessel disease, in a non-LAD with multivessel disease, in an isolated left main stem, and certainly in the acute patient, as I've mentioned before. So I don't think anyone's going out of a job in the near future. And actually, to be honest, we should all be doing more, because what Professor Taggart showed in that data that he showed about the different European countries, we are a backwater with a very low revascularization rate, despite the fact we've got a very dense patient population with a very Western diet. So these guidelines have already been shown, and I think it just reiterates what I've said. The proximal LAD, which is straightforward, the left main stem, which is straightforward, the three vessel disease, which is straightforward, which David may disagree with, and certainly we should not be going anywhere near with stenting these diabetic patients, whatever their syntax score actually is. I think that's been dealt with already. So in terms of the meta-analyses, does that help? I find meta-analyses quite confusing. And I think Professor Taggart's given the original data, which will be better than any meta-analysis. Now, David also made this point about how many real patients go into trial. Well, I think it is 5 to 10% only. The huge iceberg of disease is below. And I would argue that it's not absolutely certain that the iceberg below has a greater benefit either from stenting or from surgery. They haven't been tested. And I think you can't just make the blasé assumption that bypass would definitely be better because they have more severe disease. They're going to be more complex patients with more comorbidity, because that's what happens. You take the simpler ones into most trials. I'll mention only this one trial, which is the long-term 10-year follow-up. And perhaps I've got a slightly different interpretation. When they originally published it, then death at 10 years, if they drew the line there, was actually reasonably similar. But if you had death at longest follow-up, I completely take Professor Taggart's point that bypass surgery was winning. If it was winning, then it was based on the syntax score as a differentiator. And in the left main stem population, there seemed to be less of a difference if there was isolated left main stem. The argument that rages always with interventional cardiologists is that the trial is almost out of date as soon as it's published because we made angioplasty better. And as David has pointed out, really every single time we've argued that, although the gap between surgery and angioplasty is narrowing, I don't think it's narrowed fully. And of course, at the same time, with full arterial grafting, surgery could also be improving, although full arterial grafting just doesn't seem to have taken off in the way that drug-eluting stents may have taken off. And I'm not sure why that is. So if I summarize, then I think we'd agree for the diabetic patient, which has been assessed both in cardio, which I was involved with, and also in best and freedom, then really bypass surgery is of course better, irrespective of the syntax score. If you have a non-diabetic, then a low syntax score patient could be offered stenting, but actually I agree it should be in the context of a discussion with them. And I think the duration of follow-up is vital. I think at 1 year, angioplasty always wins. At 5 years, it looks like CABG wins. I just wonder what happens at 10 to 20 years, if there's a catch-up or not. It may be the curves come together again. We just don't know because we haven't followed up. So I'd like to try and make this now interactive. So hopefully others will be able to comment. And we've got 3 surgeons at least with us. So perhaps we could share the cases. So case number 1, 72. Really a robust looking man, referred from one of our vascular surgeons because he's working him up for really severe intermittent claudication with a near total occlusion of both common iliacs, remarkably with no carotid disease at all. So the vascular surgeon did a CT coronary angiogram and that showed a lot of disease, LAD, circumflex, right coronary. He then did a stress echo which showed LAD and circumflex was positive, the right coronary artery may well be ischemic. However much you beat this man up, and he can walk reasonably extensively despite his claudication, you cannot get an anginal symptom out of him. He has no symptom. And so then he has an invasive angiogram. And the invasive angiogram, I'll show you some stills, suggests left main stem, LAD, circumflex, and right coronary artery disease. And I did this angiogram. And I stopped and I said, look, this needs further discussion and we'll have a look and see what you think. He has hyperlipidemia, which has come under good control. And as I mentioned, the peripheral vascular disease. So I suppose the angiogram, which is the left main stem I showed you before, shows a very tight ostial right coronary artery lesion. It shows this haze in the distal left main stem. And then there is a proximal LAD lesion here as well. And the IFR shows that a lot of the dropout occurs at the left main stem, both in a pullback from the circumflex and a pullback from the LAD. It seems to be the left main stem that's the dominant lesion. I didn't bother to pressure wire this lesion, which is excruciatingly tight in any case. So we've got a gentleman with an ostial or proximal right coronary artery lesion and a physiologically significant distal left main stem. So can I open that to the floor and ask whether people would choose medical therapy? He's got no symptoms, angioplasty or surgery.
The one thing about this patient, the one thing we will do in our MDT discussion, now if we think the carotid, if we think the left main is significant, therefore we will consider obviously an intervention. And I think given the evidence and discussion we've had before, we'll probably offer him a surgical intervention. The one thing we do need to see, though, maybe just to confirm these beliefs, is an ischemia in a perfusion defect study of some sort. The right coronary artery, in theory, can be fixed with a stent if the left-sided lesions were not significant and there's no inducible ischemia. So that may change the argument if we had this investigations available.
So the stress MRI showed LAD and circumflex barn door ischemia. And the right possibly ischemia.
Okay, sorry, I missed that. In which case, I think we'll definitely offer him surgery in our department.
I'll go next, and then Professor Taggart as well. And I would personally see this patient, have a look at him, and there's a prognostic benefit. I'll do a CT aorta to make sure he hasn't got any more calcification around the ascending aorta and other parts, and see if the mammary is okay. If they are, I would offer him, and a couple of my colleagues as well at our institute I'd offer him bilateral mammaries and a radial. The radial will take on the osteal 90% lesion, and the lima to the LAD with a wire graft to the OM will function well for him in the future. I would do that on pump. I've got Chandra online, so Chandra most probably will do it off pump, but let's get his thoughts and then Professor Taggart. Chandra, what would you do?
Hi, good morning, everybody, for a nice lecture, both of you. For this patient, if he is fit enough for physical examination, I would offer a bilateral IMA on the left radial off pump.
David?
Sorry, yeah?
Yeah, can you hear me?
Yes, Professor Taggart, go ahead.
Thank you, great. First, can I congratulate Dr. Malik on a great talk? I mean, really well thought out, balanced presentation. And if you think of what Dr. Malik has said and what I've said, there's not actually a great deal of difference between us, really, in reality. So thank you, Iqbal. Really, really great, thoughtful presentation. So in terms of this patient you've just shown me, I'm a little bit less sure about surgery in this patient, because on the angiogram I saw, what I could see was some distal haziness in the left main, very tight proximal right, and then relatively proximal LAD disease. And I may have missed it, but I didn't actually see any convincing independent circumflex disease, although maybe I just didn't see it properly in your angiogram. So I would have thought this is a case where there's a more balanced discussion of, because if a cardiologist said to me, well, look, we can treat this left main easily, plus he's got a fairly straightforward lesion in the proximal LAD and a very proximal right. To me, that would be something where I wouldn't automatically say this. I'm not saying surgery is the wrong answer, but here I would have thought this is a more balanced discussion, because to me, this looked like a case that could be treated very well with PCI.
Okay, David. I mean, I'm interested, and it's a great case to discuss, because I would have thought the surgeons would have said this is a slam dunk surgical case. The intravascular ultrasound, which I haven't shown you, showed that distal left main stem disease went into the ostium of the LAD and the ostium of the circumflex.
Right.
Everything is stentable. There's no lesion that can't be stented, of course, but this would be a left main stem bifurcation lesion, which is in the more complicated range. Certainly doable. Okay.
So that would, with that information now, that would steer me towards surgery, because I would feel much more comfortable. As Chandra said, here you've demonstrated that there is significant functional disease in the proximal circumflex. So now, as Chandra said, that would be a great case for bilateral ITA grafts. But the point I was trying to make was, if it had not involved the proximal circumflex, in other words, it would be a one stent strategy from left main into LAD, I think that would be a perfectly reasonable option, because the patients I think do better from surgery, or where surgery has more to offer, is where you've got a lot of additional complex proximal disease. So it was isolated in the right, it looked fairly isolated in the proximal LAD. I prefer to see longer, more complex lesions, because that's when I know my arterial grafts are going to do better.
Wonderful.
For discussion sake, are you guys hearing me?
Yes.
Yes.
Until Iqbal said about the ultrasound, I was thinking, why not do a stent to the RCA, which is probably quite an easy peasy job for you. And then, because there is a left main and the proximal LAD, it will be a long stent if you put from there, whether to do a hybrid, which seems to be, I'm doing it for discussion. A Lima to LAD as a mid-cab.
Okay, no, I think these are interesting thoughts. I'm going to give you one more fact, okay? This chap also, went on his blood results, also has blood tests. So his lymphocyte came out as 80, and he's got a diagnosis of CLL. And I think the CLL diagnosis was discussed at our MDT. And even that diagnosis did not deter the surgeons from saying, look, this could easily be done. There are three analyses of CLL patients having bypass surgery, which I'm sure you're aware of. The really old one, there was a lot of infection afterwards. The latest one showed that the acute infection rate was very similar in the CLL population. Their average lymphocyte count in the study was about 65. His is 85. He's never had an infection in his life. He's never had any treatment. I won't labor the point because I think, with a bifurcation left main stem stenosis and a proximal LAD, a proximal right coronary artery, if he didn't have CLL, I think surgery is best. If he has CLL, I'd be interested actually for a quick answer from the surgeons, whether that actually affects your decision making in untreated, very stable, no history of infection, no suppression of his platelets or the hemoglobin. Would you still offer surgery?
Alex, do you want to go first?
Yes, I have done patients with CLL before, but they had very extensive disease and the PCI options were not very attractive. There is definitely a risk of increased infection. In terms of mortality, very difficult to quantify the risk of that when you do surgery. So given this new information, I may be a little bit less eager to offer surgery. And this is where you have an involved discussion with the patient, and we discuss the various options and get their viewpoint. As everyone said before, these lesions can be stented. I think a bifurcation left main, there's increased complexity of intervention, but it can be done. So in the first instance, you may want to achieve some improvement in his revascularization with stents, and then consider surgery in the future if the leukemia is managed properly.
Okay, so that's great. So I think because I want to try and get through 5 cases, which we probably won't do. If we have a quick answer from the other surgeons, yes or no to surgery now?
Okay, I am yes for surgery still, as long as we do a skeletonized, delicate IMA harvesting. And also, the weight of a hybrid now goes higher because of the CLL avoiding a sternotomy. Hybrid with the mid-cab Lima to LAD and then stent to the RCA, plus or minus circumflex left main.
I would have a discussion with the patient and yourself together and discuss with the patient whether they have, again, bilateral skeletonized IMA on pump with an endoscopic radial to reduce wound infection. But yes, it'd be less attractive, but I would still offer the option with him with full consent. Professor Taggart?
Yeah, I mean, very interesting the way you're building the case up, but my opinion would remain the same, that I think on balance, CABG, but the clear point that we don't know here is, I would want to know from an experienced consultant hematologist, what is this man's prognosis from the CLL? And that's what I'm not clear about. If the hematologist said, look, this isn't going to affect this man over the next 10 years, then I would put that on the back burner. I don't think it'd be relevant. If the hematologist said, well, there's a 50% chance he'll be dead in 3 or 4 years, that would change my opinion completely.
Lovely, David. So I think I'm completely aligned with you. So I think it was right to take him off the table, to have a detailed discussion, to discuss it at the MDT. And in the end, our surgeons also said, look, I could still do this. The data suggests that the infection rate can be easily managed. And so all of your surgeons are saying that we probably still offer surgery, and that's not a bad thing. The patient voted for PCI. And actually, because I'd taken some time to think about it, here is the politics, David. Okay, he then went off to another person to have the PCI done. Okay, because I'd clearly taken too long in thinking about it. I wasn't gung-ho enough.
Well, you'll see that on this line is Shaquille Farid, and Shaquille and myself always go to our MDTs and ask Shaquille Farid how many patients, when we present to the patient the view of the MDT, does the patient then turn around and say, no, I don't want to follow that advice. I want something different. Because in my experience, it's genuinely very, very uncommon.
But that's a different question, David, because in this patient, I think generally there is a discussion about which treatment. He's got a very good prognosis. And so I think he was offered either. Okay, and I said, look, there's pros and cons to both. It was worth having the discussion. But actually, the point I'm making here is that he found that discussion too tortuous. And he got a second opinion, where the man had absolutely no discussion at all. He said, of course it's angioplasty. And actually what he told him was, based I think on just the angiogram and not my letter and not the physiology data, was that we could probably leave the left main stem alone. I won't name that interventionist, and I don't know what he's actually going to end up doing, but it shows you that the patients will make a choice, however good you think you are and however good the detailed discussion is. I mean, my letter went on to a couple of pages describing the pros and cons, and he's going to end up having a smash and grab angioplasty, I think.
So Iqbal, I completely agree with you, but of course, if it's a situation where, because remember from the outset of this case, I said I did think it was a more nuanced decision. I did see a potential role for PCI. And I think if you say to the patient that we think either of these treatment options, you could do well with either, then of course the patient's going to go for the less invasive one. So if you cannot have a discussion with the patient where you are indicating why you think one treatment is better than the other, but you present it saying, well, we could do it either way, then I completely agree the patient's going to go for the less invasive option.
Yeah, no, I agree. I think the point I was illustrating was that hesitation that I had in making discussion has meant the patient's gone to someone who seems to have totally underestimated the left main stem. And I hope God that when he's actually doing the procedure, he discovers the left main stem as it is, because it is significant.
Yes.
So I'm going to move on to the next case. So case 2, 68, smoker, cholesterol's okay, not diabetic. No other comorbidities, arrived with an ST segment elevation inferior myocardial infarction. The bystander disease was severe circumflex disease and labeled as moderate to severe mid-LAD disease. You guys do not yet know the troponin will be 10,000. First question, that ECG arrives, there's 3 vessel disease with 1 vessel occlusion. Is anyone taking this patient to emergency surgery? Because as I say, I've never managed to persuade a patient, however nasty the coronary disease was, I've never managed to persuade one of our surgeons to take the patient acutely during a stenting. I
completely agree. Taking this patient to an operating room would be completely inappropriate.
I will not take him to theatre.
I think that's fairly clear. So we'll move on. So he's got mild LV impairment. He has his right coronary artery stented. Okay. So that's stented. He's recovered. He's an inpatient. He's got significant circumflex and LAD disease. And so would you want to take him, because there was no pressure wise or anything done at the time of the primary angioplasty. Would you accept the angiogram, which I'm about to show you, and just say, okay, well, now we're going to bypass him? And if so, how long will it take to get the bypass done? Or would you say, listen, you've started on stenting. These look reasonable for stenting. Just keep on stenting. So those are the thoughts that I'd like you to have when you're looking at these. Okay. So the right coronary remained patent. The LAD has a moderate mid-vessel stenosis, which is, you can just appreciate, between the 2 diagonals. And there was a circumflex which had a very tight lesion, which you saw on the first. So that's the disease. Here's the circumflex coming up. So a tight OM lesion. And so we did a pressure wire to the LAD because I thought it was quite a moderate lesion. And the pressure wire is 0.93, which is sort of negative, really. Okay, so thoughts there. Would you have actually bothered to get the patient back onto the table to do the pressure wire on the LAD? Would you have said, look, this patient needs surgery because he's got LAD right coronary artery sorted out, but the circumflex still needs doing? Or would you say, look, this is an angioplasty candidate? What do guys think?
I think you did the sensible approach, is that LAD lesion looked moderate and it needed IFR or whichever flow testing system you use at your institute to prove that it's negative. And from what I've seen on the angiogram, I didn't see any other lesions. So I agree with you. The LAD is not significant. There's no left main. So I would recommend he have PCI to the circumflex. Alex?
I would totally agree with that. I think it's the right thing to be done to assess the stenosis of the LAD. The only question to ask, maybe bounce it back, if he's asymptomatic and he's got this lesion in the LAD, would you still offer him a stent?
So certainly not to the LAD.
Circumflex.
So there's quite a lot of data now that if you if you treat the culprit at the time, which is fine, if you then leave the other disease alone, there's a pretty high incidence of the patient coming back for more. And I think it's not just the oculostenotic reflex, they actually get more symptoms and have a slightly higher event rate, because it's quite clear that when you have a STEMI, there's usually a field change, and often we've missed another lesion in about 40% of cases, which was also hot, but you couldn't see it because it wasn't completely blocked. So the vote now is to actually try and complete the revascularization after a STEMI as an inpatient, if at all possible, to try and reduce the recurrence rate.
Is that based on the PRAMI study results? Or?
It's PRAMI and also culprit, and there's one other trial whose name I've now forgotten. There are 3 trials which actually suggested that do it sooner rather than later actually reduces event rate.
Yeah, I think I completely agree with your strategy here. I think one of the problems with some of these trials is in these patients with acute presentations, many of them are not already on optimal or guideline-directed medical therapy. So essentially, you've got a very good result in the RCA with this patient. You've done the right thing by confirming that the LAD lesion is not functionally important. So this is now a patient down to essentially one vessel disease. And if the patient has not yet had a trial of guideline-directed medical therapy, I think that would be a justifiable option as well.
Okay, I think that's pretty clear. So I think most interventional cardiologists, however conservative they are, and I'm quite conservative in terms of surgery versus angioplasty, I think it would be very difficult for them to leave that lesion alone in the circumflex when they've had to bring the patient back to the table to have a look at the LAD in any case. There is a further trial called iModern that Imperial is running to again look to see whether this bystander disease with functional assessment absolutely needs to be treated or not. Okay, so next case, 75, 2 weeks of exertional discomfort, came up to a chest pain clinic and actually got admitted because we were worried that, remember, this crescendo angina pattern, the next thing might be an acute myocardial infarction. So at the clinic, he's got a normal ECG, a normal troponin, very mild aortic sclerosis, not stenosis, and good LV function at the age of 75. And he ends up having a coronary angiogram. And you can see that he's got really quite atrocious disease. He's got an ostial left main stem. He looks like ostial LAD disease. He's got proximal circumflex disease also. And you can see everything seems to be hanging by a thread. And the kisser is that he's also got blocked right coronary artery. So what do we think about this set of coronaries?
Yeah, so does he have any other significant comorbidities?
Nope.
No. So, I mean, this is a man with really complex coronary artery disease, and you can argue that patients like this have never actually been in the trials, you know, specifically to some extent in patients with left main and the high syntax scores they have. But if this was an otherwise very good, robust 75-year-old, I would say to him that I think that he has now presented with unstable angina on the background of very complex coronary artery disease. If you're otherwise happy, I think you said he had a bit of COPD, but I take it that's not particularly common.
Very minor, very minor.
Fine. So I think you could offer CABG to this patient with a risk of around 1 to 2%. And if he's a 75-year-old whom you genuinely believe has another 10 years of life in front of him, then I think CABG would be a very reasonable option.
Excellent. Okay, I think no one's going to disagree with the fact that this looks highly unattractive for angioplasty. And if you can find some targets, then he's likely to live longer with a bypass operation and done on that admission and not sent home to die.
Yes.
But done on that admission. And, you know, it is incredible how some of these patients get discharged because there's a problem with the beds at the moment. I would not be sending this man home. On day 5 of his admission, he's not yet had his bypass operation. He got an acute episode of abdominal pain that required acute appendicectomy and then spent some time in the intensive care unit. Whilst on the intensive care unit, obviously antiplatelets have been stopped, but he was troponin negative in any case. He gets some very minor biphasic T-wave changes. The T-wave changes were really not impressive, but his LV function fell off a cliff. So he's gone from normal to severe impairment with infralateral, inferior, infraseptal, and apical akinesia. Not thinned. Remember, this was all happening fairly acutely. And his troponin has shot up to 40,000. So now we've got a gentleman who's clearly, although it's recalled an N-STEMI because the ECG did not show ST-STEMI elevation, it's a massive myocardial infarction. And with that, his kidneys have started to go off. He's had a yo-yoing course in hospital with the kidneys getting better and getting worse, presumably because he's got a low output state now that he's recovering from his sepsis. So I presume that none of you would disagree that he's now not a very attractive surgical candidate, or would you disagree and say, look, prognostically, this man still deserves a bypass operation? What do you guys think?
Yeah, it's certainly become less attractive following these events. But there is a possibility if we think the anterior wall is still at risk because the LAD is still functioning, and we're assuming it's an inferior, probably circumflex occlusion that's caused this. Then it's a possibility we can think about to discuss LAD off pump. But I can see that if there's any PCI option again, we will certainly discuss this at MDT and see how convincing we think the option of reopening the LAD percutaneously might be.
Professor Taggart, your thoughts?
I think your strategy is absolutely correct in a case like this, because whereas you would have started with an operative risk of 1 to 2%, in while his ventricular function was good, I think the scenario has changed totally now. Now, what you don't know in these situations, and sometimes it's difficult to get it right or estimate it, is sometimes we've all seen this, a ventricle can take a sudden hit and the whole ventricle can look globally impaired. And yet if you manage them conservatively, 5 days later, the ventricle can look completely different again. But given the scenario you're faced here, I have absolutely no question that PCI was the right strategy. What I would have been very interested, Iqbal, to discuss with you, not to change your mind, but just out of interest, what PCI risk would you quote him given his now different clinical scenario? So you're doing a very high risk complex PCI in now on an unattractive background. So just out of interest, what kind of PCI risk would you quote in this situation?
I quoted to him a 5% risk of death during the angioplasty, and if we didn't do anything, probably about a 20% risk of death.
I agree for stenting and angiogram, and probably stenting is the best option here. I was just wondering, what is the panel view putting a balloon pump if he's high risk, unattractive PCI?
So I'll answer the balloon pump question, say that the evidence base for that from all of our trials now, because there was a trial done in the UK, shows that the balloon pumps don't really add a great deal to the shocked patient. If we were going to do something, then we might choose an impeller device. And there is some data that the impeller really does make a difference. However, at Imperial, we don't have impeller. And the reasoning behind it is cost. And actually, if we did have impeller, then all the TAVI operators could put it in because it's large bore access. But actually, if my other interventional colleagues want to try and put large bore access impellers in, they may create more complications because they'll probably be using it 2 or 3 times a year each, which is a very bad thing to do. So hence, we haven't pushed for getting the impeller. So this gentleman ended up having the anaesthetist in the room, but they thankfully weren't called upon too much. He had very poor radials. It was done femorally. Most of the time I do everything radially, including complex intervention. And he ended up with the left main stem being stented and then a spot stent into the circumflex and getting out of Dodge, basically. I thought I'd done well to get out of there with the patient still alive. And he's then continued to have his recovery. And he got out of hospital. This is now a couple of years ago. He's not come back for more intervention, as in fact, he had a very reasonable size infarction with scarring. And now the benefit of a lemur to the LAD, which is what's left to do, the right was a non-dominant lesion, in fact, is, I think, quite limited. So I think it was a good result to get him out of hospital alive.
Very good result.
I think we've time for one more case in the time allowed. So this is a 44-year-old gentleman who's diabetic, hyperlipidemic, hypertensive. And he presented with an ST segment elevation marker infarction in cardiogenic shock in 2016 with a stent into his left main stem, into the LAD, and a stent in the right coronary artery. And as they often do, once they're revascularized, they recover amazingly. One of the cases that the BBC came and filmed when hospital program was at Imperial was a cardiogenic shock patient who had multi-vessel stenting, came in pretty much dead and went home at day 5. My daughter happened to be doing work experience with me when he came back to clinic 6 weeks later. I must say, I got quite emotional about that situation. So here's his angiogram about 6 months later, this chap. So remember, the left main stem into the LAD was stented and the right was stented. And so the left main stem is patent, but the circumflex has a pinch at the top end, and the LAD beyond the stent has quite significant disease. The right coronary artery has disease in its segment 3, with vessels which are a little small, but possibly graftable at the bottom end. The proximal right coronary artery stent is patent. So we've got a diabetic gentleman who has now got significant residual disease, no real restenosis in the stents, and we're left with a decision to make in the cold light of day. So there's a right coronary artery. What do we think?
Okay. I'd like more information on the LAD. The circumflex and right are tight enough for grasp, but I want more information on that LAD lesion via FFR or IFR. And that would then govern what my strategy would be. So Iqbal, it's operator dependent. Is that positive or negative? I'll throw it back to you.
That's IFR. IFR below 0.9 is positive, and 0.77 is highly positive. So FFR, the cutoff is 0.8, but IFR it's 0.9. So this is a highly significant result.
Well, fine. Then he's got triple vessel disease for me in a young patient, so he would get a total artery revascularization. He's got tight enough disease. Professor Taggart, your views?
Yes, yeah, I completely agree. The other interesting thing, and I agree that he should undergo CABG. It should hopefully be optimized with as many arterial grafts as possible. The other things you need to consider: what body habitus is he? Is he insulin dependent diabetes? And does, because the other thing at the back of your mind here is you want to maximize your strategy with arterial grafts. They should do well because of the highly positive functional stenosis. And one would hope to use 2 skeletonized ITA grafts, but what body habitus is he? Slim. If he's slim, then definitely go for 2 skeletonized ITA grafts.
Okay.
And hopefully a radial for the PDA.
So I want to offer you this extra information because part of the technology we developed at Imperial is the IFR Scout. So you can do a pullback. And so this is an LAD with very diffuse disease. As you can see, there is no one spot which has a big jump. And I think that's an education for all of us in that these sort of vessels respond less well to stenting, and I think also bypass surgery, than the vessels with a more focal stenosis at one spot can be easily bypassed. So again, because of interest of time, I'll go on and say he had a bypass operation. In fact, a CABG times 5. So Lima to LAD, vein graft to diagonal, PDA, PLV, and OM. We don't have a very high rate of total arterial revascularization at Imperial. He struggled a bit. He had pulmonary edema. He had pleural effusions. He didn't get recurrent angina until about 3 months later, and a repeat angiogram showed that the Lima had actually failed, as had the vein graft to D1 and the PLV, but he had 2 patent vein grafts. So I think this is a man who's young but older than his years, with much more diffuse disease than expected. And I'm not sure how long he is for this world, whatever we'd actually done. He survived his heart attack, and then he survived his bypass operation, but he's still left with his comorbidities. And I think I would illustrate to say this diffuse pattern, which is the point of showing this case, not to say that the surgery was bad, I think the patient was bad, is that if you have rather diffuse disease, then I think be very wary of what the Lima is actually going to do. And it may be that the lemur in those situations might be put on a slightly different vessel where you have more chance of success. So case 5 is a 76-year-old lady who went an angiogram for a troponin positive acute coronary syndrome. Again, she is diabetic, hypertensive, hyperlipidemic, but also has end-stage renal failure. She's not fat or slim, she's average. And the angiogram was done by one of my colleagues via the right femoral approach. So remarkably decent distal vessels, but remarkably bad left main stem. There's no flow back from the left main stem into the aorta. And it was a non-dominant right coronary artery. Okay, so end-stage renal failure, diabetic, hypertensive, hyperlipidemic, who presented with a small troponin rise.
So what I would like to know in this case, so one would start off with the premise, severe, at least proximal disease, with reasonably decent targets. The worry obviously is in someone who, and the fact that she's got diabetes would normally push her towards surgery. However, again, I'd have to ask, what is if you have end-stage renal failure, 50% of these patients are dead within 5 years. So, and she's 76, I think you said.
Yeah.
So what would be the PCI options here?
So she would get a intervention to the left main stem. I can't fully image the left main stem at the moment, and therefore on the angiogram, which is what we saw at the time, I would say, look, it's doable because the origin of the circumflex looks widely open, so it might even be a one-stent strategy, but certainly doable by stenting because there's landing zones in both vessels.
I think that would be, I'll be interested to hear my surgical colleagues, but I think that would be a very reasonable strategy. And also, I don't see a lot of other, proximal disease apart from the left main, unless I'm misinterpreting the angiogram.
No, it's again a bit raggy, but
yes. She's 76 and she's got a bit of diffuse disease, but I don't see really, good quality, very highly significant proximal stenosis.
Alex, your thoughts?
I would totally agree with David here. I think, if she gets revascularized, the prognostic benefit of surgery is not here in her case because she'd be dead of a renal failure before that. So I think a PCI option is the preferred option here, in my opinion, if it's doable.
Chandra?
I will probably lean towards surgery if a patient is otherwise fit enough. Even though age is 75, there is some disease in the mid-LAD diagonal area there. We need to see the angio much more.
Okay, I think we are limited by the small screens we're looking at the angiograms on. I completely agree.
Yeah.
So she was referred for stenting. On the diagnostic pictures, it looked like the left main stem was very, very short, didn't it? Okay. When we get to it, the pictures haven't changed much. She doesn't like having catheters in her coronaries. But actually, once you put a wire in, you can see that there is actually a slightly longer left main stem, which is diseased all the way through. So that's then stented into the LAD, optimized into the circumflex ostium, because I think with these very big bifurcations, then you do need to open up the stent struts into the circumflex. Otherwise, you're leaving a meshwork across. So she's had a KISS balloon inflation, still one stent. And then you can see that the angiographic results looks good. Not good enough, because I think if your interventionists are doing this without intravascular ultrasound, they've gone mad. So intravascular ultrasound shows that the stent is well deployed, and actually at each spot, whether it's an adequate circle and when you've got enough expansion. And so this is after the second balloon inflation into the left main stem. This is a very good expansion of the stent, well deployed. It was about a millimeter squared more after the second inflation, which is now an optimized stent. So we've now got optimized. Of course, it's still a bit oval in places, but we've already done high pressure balloon inflation, and I think it looks a very good result. And again, she's got no recurrence 2 years later. So I think in summary then, I think we need to know the data, and David's given a great example of what the data shows. And I think what we've shown with the cases is that you've got the data, and then you've got the patients. And actually, probably the most aggressive angioplasty in the room turned out to be, which I think illustrates the point of the MDT. And so complete revascularization, I think, is absolutely key if you're in an elective situation. I think some of the cases I've shown you, getting out of Dodge, doing as much as you need to is a much better prospect because the patient's in extremis. Absolutely, you need your best medical therapy, and I've illustrated that as well. We've gone into patient choice, which is difficult. I think you can lay it on the line and give them a binary choice, and I think they may well accept it. But I think that's an Oxford patient rather than a Hammersmith patient. And I think if the choice is not binary, the patient is often very confused by a 60-40 choice. Those who are easy are the ones who say, "Doc, what would you do?" That's easy. Those who try and think it out for themselves tie themselves up in knots. And then the final thing which we don't have is what's happening in your unit. Because unless you know what's happening in your unit, with the results for multivessel disease or proximal LAD or left main stem, then I think it's very difficult to really tell the patient what is the right thing for them to do. Thank you very much.
Can I just say a quick comment if you're still online? Yeah. Yep. So just to say, first again, I'd like to congratulate Iqbal on great presentation. And what he's done beautifully. I've shown you what the evidence for CABG versus PTI is, and I think everyone attending an MDT must be aware of that information and be quite familiar with it, because it is important in informing discussions. But I think what Iqbal's done fantastically is show that that evidence is only part of the answer, that the other bits you have to take into consideration. What are the specific patient-related factors that can influence that evidence basis? And then finally, once you do think you've combined these things properly, make sure the information is presented to the patient in the most fair, balanced way, because one day all of us might be patients, and there's not one of us here today who'd say, well, I'm not particularly bothered about getting the right evidence or opinion. When I take my car to the garage, I've got to follow the opinion of the mechanic and take it on the face of it, that the mechanic's telling me appropriate information that allows me to make my informed decision. But again, let me also just congratulate the course organizers for this truly great session. And finally, again, to Dr. Malik, I think it's been great coming here today, and he's educated all of us.
Absolutely, I agree. It's been a fantastic debate. I just want to share one bit of information, because we've got we've got 4 real arterial grafters, Professor Taggart, myself, Alex Cipollini, and Chandra. Now, I'm just going to share my screen just to show you. I was mainly trained, I did my SR at Imperial and was mainly doing one mammary and lots. And you can see, this is my data from St. George's over time. So initially I was just doing vein and mammaries. Then I moved on to a bit of radials. And you can now see, as you go through time, I went to bilateral mammaries, increasing the usage, and then bilateral mammaries and radials. So what the point of this was to show that you don't have to be trained. You can do it as you go through your consultant year. And you can look back at 2018, 53% when the disease was severe enough of my isolated CABG populations had bilateral mammaries. And that's what I want to tell the younger ones. You can develop your practice as you become a consultant. You not necessarily have to be completely trained fully in training. You can develop yourself, continue to develop yourself throughout your career. And I think with the cardiologists, like Iqbal says, they don't have much arterial vascularization at Imperial. There are units like St. George's, Oxford, and other units who do a lot of arterial vascularization. I think there's about 3 surgeons at our institute who use bilateral mammaries as like a default, as long as the stenosis is significant enough. Any other comments? We have 2 polls to run as well. Sorry, there's a 3 polls to run, which we'll run now, and then we can just question. So I don't really think there's a winner of the debate, but we'll do this. Who do you think has won the debate? So we'll have that's 1 poll. Can we run the second poll at the same time?
No.
Okay, let's see the answers.
While the poll's coming up, I'd say that there is no consultant who can hand on heart say they're not learning with every single case.
Yeah,
if they are, they need to be sacked immediately.
So I think the debate, I think because you've come into the lines then, Iqbal, but I think your talk was very balanced. Professor Daggett was 63% to 37%. Can we do the second poll, please? Again, that's the first one. And we've shared results. Okay, this is from Alex Cipollini. Question: what do you want if you have an 80% proximal LAD stenosis? You want PCI, CABG stenotomy, or a mid-cab? Now, don't forget, most of our delegates will be surgical based, but it's interesting. Oh, very interesting.
What they're thinking about that, I think it is, again, what I suggested about what you think about this poll. They're young, all your delegates, I think, and they're nowhere near having an LAD stenosis, so they're having a sort of theoretical discussion. The older ones amongst us, where we're getting closer to this actual stenosis, it's prey on your mind what you actually will have. It's a different decision.
Okay, there we go. So you're right, Iqbal. 1 in 3 still wanted PCI despite the evidence. 1 in 3 wanted a stenotomy CABG. I don't know why. And 40%, if I had a patient like that, I would refer him for mid-cab or do a mid-cab with my senior colleague, Chandra. Let's run one more poll, the third poll. This is a question from me. In your institutions, now this is not you, I'm asking, in your institutions for severe complex free vessel disease, what will be the treatment modality? Would it be multi-vessel PCI? Would it be CABG, Lehman veins, or would it be total arterial revascularization? Now we know from the data from the STS and SCTS, arterial multi-arterial grafting is somewhere between 5 to 10%. So, yep, we can share the results. And yes, and it comes in at that as well. Yeah, you go. 10%. And that is a problem we're going to have until we recognize coronary artery disease as a subspecialty in its own right, like mitral valve disease, like aortic valve disease, have heart teams to progress this disease and have surgeons who are willing to do arterial vascularization, use endoscopic vein, endoscopic radials. It will always be the poor man's part of cardiac surgery. Any other, Professor Taggart, I'll give you and Iqbal the last comments before we move on.
No, just, I mean, very good polls, very interesting answers, and they're all worth debating in their own right. But again, I think today's session was great. So congratulations to you and Alex, and again to Dr. Malik for his great contribution.
And I'd like
final word, please.
I'd like to say that it was amazing to hear David talk. So I've heard him before at cardiology meetings. He's obviously in home base here, but actually he gives the same talk every single time, doesn't he? He's got the evidence. The evidence is the evidence, and it was a pleasure to be here today.
Can I just say a big thank you to both the speakers? Really excellent debate. I really enjoyed it. Dr. Malik, you're a very genuine cardiologist who thinks of the patient, which is really, really good. And I wish there were more of you around the place to make proper decisions. So very enjoyable, great discussion. Thank you very much for your time.
Thank you, everyone.